Now, take a look at this, the STAR D program, and this is has been completed now. They're still doing some research with it, but it was done basically in 2007. Now, there's a couple of really good things about this study, and there's a couple of weaknesses also. Good thing number one, it's not supported by drug companies. Probably 90% of research done in psychopharmacology is getting money from a drug company, so you can't rule out sort of cost marketing incentives and stuff like that. But the other thing is that these people are really sick. Okay, they have severe depressions. They also have a lot of comorbidity. They have access to disorders, substance abuse. They have medical problems and that sort of thing. So that's what they wanted to do. So let's look at the people we actually end up treating. Right. You can see here 80% have either chronic depression or recurrent. 25% coming into the study have been depressed continuously for the last 2 years. And again, like with most studies, about half have either agitated, anxious depressions or depression with comorbid anxiety disorders. Now, let's look at what they found. This is an empirical study. It's not being directed by anybody, personal opinion about this. First off, they chose the drug Celexa. Now, there's a good reason for that, and that is Celexa is one of 3 drugs, antidepressants, that have no drug-drug interaction problems. I'm going to tell you what the 3 are: Celexa, Lexapro, and Zoloft. Now, the reason that's important is because they had, older people here. The older you get, usually the more prescription medications people are using, and they did not want to complicate things by causing adverse drug-drug interactions. So they chose Celexa. And what they did is they treated these people, and you see here the response rate was 60%. But like we talked about before, response doesn't mean remission. Okay, 30%, which would be half of the responders, went to full remission, and the average time was 7 weeks. And that is not too bad. If you look at really sick people, it may not sound very good, but this is no psychotherapy. Now, they did have a psychotherapy arm to the study, but I'm not talking about this. This is no psychotherapy with really sick people, 30%. Okay, it's not stellar, but it ain't too bad. The key was aggressive dosing. Phase 2. Okay, what they did here, and I think this is a very good part of the study, anybody that didn't completely remit. So these are people who have no response, poor response, or partial responses. Then they said, okay, let's do something different. Phase 2. So what they did here is they randomized them to either switching to a different drug or adding a drug, augmenting. All right? Now, here's what you see. Remember, we're starting off with 30% reached remission, okay? Now we've rescued this many more with these drugs. They're taken off of Celexa and put on these drugs. Now, what is interesting here was especially interesting a few years ago. They said, wait a minute, Zoloft is also an SSRI, and so is Celexa. How is it that we're getting additional benefits from giving a drug that targets the same neurotransmitter system? Okay. Well, there's 2 possible explanations for this. Okay. One of them is that what's been discovered in the last year is that with high doses of Zoloft, it starts increasing dopamine, and this was not known. Actually, if somebody really wanted to quiz you, you won't get this on your exam, but if someone says, is Zoloft truly an SSRI? Probably 99% of physicians would say yes, and the answer is not at high doses. It starts affecting dopamine. But the other thing is just absolute speculation, and that is what's known is that many drugs, to a greater or lesser degree, have more or less ability to cross the blood-brain barrier. And it's possible that even though they have the same mechanism of action on the cells, that their ability to actually penetrate into the central nervous system may be somewhat different. Now, what this means practically, and everybody says, this is coming away from STAR D, but all the experts say it's not crazy to go to a second SSRI, but if they fail that, it is absolutely crazy to go to a third, because it just ain't working, shooting at the wrong target. Now, these look different, but they're not. They're not statistically significantly different. And so now, these people have gone to remission. So what do we have here? We still have some people that haven't fully remitted, okay? Augmenting, here we're adding a drug, okay, to Celexa, and we have 30% reaching full remission. So slightly higher, but statistically non-significant edge. Now, what's the downside of this? Downside is you get two drugs, you may have two drugs causing side effects, right? The biggest mistake they made in this study, okay, is they were randomized to this. What they didn't do is they didn't follow the guidelines that were found in Texas Algorithm Project. You know what they should have done? When they augment, number one is Wellbutrin should be given to people that have anergic depressions, and Buspar, which is a tranquilizer, should be given to patients that have an anxious depression, and they didn't. Okay, they didn't do that. Okay. Now the other thing is that if you have, and they didn't do this either, if you have no response on high doses, what question?
What type of depression?
Anergic, remember, or anxious? Yeah. Okay. Now, this other issue they didn't address, and this is a real weakness with the study, okay? If you treat somebody with aggressive dosing for 8 weeks, I mean, you really push the dose, and there's virtually no response, or 5%, then, and all the experts say this, why add a drug to something that ain't working? Doesn't make any sense. So the guideline is if the first drug gets you at least 25% improvement, it's doing something. Then adding a drug may make some sense, but they didn't factor that in STAR D. Is that clear?
And so in general, the augmentation shouldn't happen unless there is that minimal increase
That's
in
right.
improvement?
That's right. Yeah. She's saying if there's not a minimal improvement, then augmenting is not the way to go. This is basically saying this drug is not doing very much, and why take the risk of having two drugs producing side effects? Okay. Oops. Okay. So after phase 2, 55% of these people, if you collapse the data, 55% have reached remission. Just drugs. Phase 3. Again, they take everybody who hasn't gone to full remission. So we have partial and poor responders. And they either switch the drugs, they take them off everything else, and they put them on a tricyclic antidepressant or a Remeron, or they augment with lithium and with thyroid. And here's what they found. Okay, so this buys another 13% of responders. The downside here is half these people are going to gain a lot of weight. Okay, with this, if they take an overdose, it'll kill them. And also, it's got anticholinergic effects, so they're going to likely get some dry mouth and constipation and that kind of stuff. So that 13% is not bad because we have very severely depressed people that haven't responded, and it rescues some of them. Okay, but look down here, 20%. But you know what the big difference is? Really, really different. And that is lithium has a ton of side effects. You got to do all kinds of laboratory monitoring, monitor blood levels of lithium. It's just a very dirty drug in terms of side effects. And T3 at these doses, 0 side effects. Okay, and what the lead researcher was John Rush, and what he said, the biggest surprise was this, T3. Okay, and we talked about this before. I think that the thyroid, low-grade thyroid problems, oftentimes, if you add just a little bit of T3, it'll make a huge difference. And that is another weakness. They didn't do any pre-screening for thyroid functioning. Now, T3 augmentation, the other thyroid hormone that's used frequently in medicine is T4. But there are 4 double-blind studies showing that T3 seems to work better. Nobody really knows why. But these are tiny, tiny, tiny doses. Okay, so going through all these phases, 67% of these patients, 2/3, reach full remission. Okay. But look at this. They stay on the medication, and by a year, we've had a number of breakthrough, reoccurrences or relapses. Yes, ma'am.
Is that 43% of the original population, the whole population, or
Yeah.
43%?
Okay. Now this is 67% of the 4,100 people, okay? And this is 43% of the original 4,100. Okay. So, yeah. But we've lost some. Okay. Now, there are people that have, written editorials, and I've heard this at conferences, this is very disappointing, and, this kind of stuff. And see, I don't see it that way. I think that this is depression. This is severe depression. And we shouldn't fool ourselves into believing that we got some kind of drug that's a panacea. Now, it doesn't have psychotherapy, doesn't have exercise. And rather than people feeling pessimistic, I think we should humbly step forward and say this stuff is hard to treat. And it's even more reason for using combined treatment, psychotherapy and medications. Okay, but this is what we're up against with severe recurrent depressions, especially. I'm not going to go. Let me just show you one of these, okay? And they're in your handout just for your own reference. But this is the protocol, okay? So let's look at Celexa, their first drug. They started everybody on 20 milligrams, okay? And the only people that wouldn't continue if they couldn't tolerate that, okay? But then if they hadn't shown significant improvement by day 28, they bumped everybody up to 40 if tolerated, and they went all the way up to 60. And you'll never see anybody take 60 in primary care. Okay, that's a high dose. So anyway, now this comes from Cochrane database surveys. You see down here in the bottom, and if you Google that, you can get on their website. And they are considered to be the best source of reliable data on research in medicine, but they also research in other areas as well. And the good thing about this is they look at studies that are methodologically sound, and they do meta-analyses. They collapse the data. Okay, so look at this: 26,000 patients here. If you and really, you can't talk about this unless you also talk about this, because if you have a drug that's really effective, if they don't take it, it's not going to work. So you can see here that of all the new drugs, Zoloft comes on top, and it's followed by Lexapro. This is also what I talked about before, SSRIs versus dual action drugs, better efficacy in treating severe depression. In terms of tolerability, if you look at SSRIs versus Wellbutrin is the best tolerated. I mentioned that before. And later we'll talk about treating pain. Elavil, the old tricyclic, is still one of the best drugs used for pain. Okay, so here's kind of, let's pull together the data from the text algorithm project and STAR D, and take a look at this. Okay, partial response strategies. Okay, this is a person that has 25% or greater improvement, all right? So something's happening. This sounds like, and I'm stating the obvious, check compliance and substance abuse. One of the most common reasons that people do not respond to antidepressants is ongoing, unreported substance abuse, especially alcohol. Alcohol can cause depression, alcohol destroys sleep, and it can jack up liver enzymes that can affect blood levels of antidepressants. So you got to go back. I've had patients I go back to and say, hey, look, it's obvious this is not really working. I know I asked you this before, but I just want to have a heart-to-heart talk with you, and that is, are you drinking a lot of alcohol? And And some people go, well, yeah, actually, I said I only had a glass of wine a day, but that glass was, like 40 ounces. Okay. And you might as well spit in the wind, if they're doing that. Okay, then if they're taking it and you've pretty much ruled out substance abuse, then the best thing to do, because they have a response, is increase the dose, right? It's doing so. So let's get that blood level up. And the only reason you don't go higher is if you're running side effects. And if that doesn't work, then you augment, right? Why do you augment? Because they are getting some benefit. Let me mention a couple of things here about augmentation strategies. With lithium, as I said before, it's got lots of side effects. It has fewer side effects at lower doses. And lithium is used, of course, to treat bipolar disorder, okay? But also it's been shown for many, many years to be good as an augmenter for very hard to treat depressions. Now, the real benefit of this are these two things here, okay? I mean, the price you pay is side effects. They're less at these somewhat lower doses, but they're still there, okay? It significantly reduces recurrence in highly recurrent depression, okay, by threefold. That's a big deal. And this is a huge deal, okay, both in treating depression and treating bipolar disorder. This is the only drug that's been shown to be this good at preventing suicides. In fact, people that are stabilized on lithium, it's very hard to find anybody who commits suicide. And this comes from very large population studies in Scandinavian countries where they have socialized medicine. Can I say that? Is it okay to say that? Okay, socialized medicine. And so they're looking at, everybody. They track them from cradle to grave and see what drugs they take and what diseases they have and that kind of stuff. So that's a big deal. So, this is another thing. You got to look at tolerability, efficacy. But what if you had somebody who's made 3 really severe suicide attempts? Okay? The plus about adding lithium is once it gets on board, you may keep him from killing himself. Okay? What do you think the downside is other than side effects? Got an idea? How about before? Okay, how about before the lithium really starts working and they decide, I'm going to take an overdose of this. It's one of the most toxic drugs in all of medicine. Okay? This is all risk-benefit. All risk-benefit.